Hi, Naomi. How are you? Nice to meet you.
Hi, good morning. Nice to meet you too. Thanks so much for being here.
Thank you.
Hello.
Hi, Eloise.
Hello there. Wow, we have 20 people already. Fantastic. Hello, Dr. Liu. Thank you for being with us.
Hello.
Okay, might just give it 30 seconds more. Hello again, Michelle. Nice to see you. I think I'll wait till a minute past, but then we'll get started because we've got another roller coaster agenda. Right, okay, we're a minute past the hour, so I think I'll not discriminate against early birds. You're all very welcome. Thank you so much for being with us today. I'm Eloise Todd, co-founder of the Pandemic Action Network, and thanks for joining this conversation to help inform the work of the independent panel for pandemic preparedness and response, which is in the final stages of putting together its reports, which it will release around the May World Health Assembly. Last week, we had the pleasure of hosting a rich conversation with the panel on socio-economic impact of the pandemic and heard from all over the world and from all walks of life. Today, we're pleased to hear again from a very diverse set of voices, this time to discuss the critical leadership systems, communications and equity issues necessary to build confidence in vaccine rollouts during a pandemic, including addressing factors that contribute to distrust and hesitancy. We'll then open the floor for an open discussion in which all attendees are encouraged to participate. Just a couple of bits of housekeeping before we dive in. You might see in the top left corner, the meeting is being recorded and will be shared following the event. So just letting you know that. And in terms of getting your questions posed, please enter your questions into the chat or raise your hand when we get to the Q&A section of the discussion. I just wanted to introduce Dr. Joanne Liu from the independent panel, who also is the international president of Doctors Without Borders, Médecins Sans Frontières, a board member of the edition herself, as well as serving on the panel. And I also see Michelle Kazachkin back again, which is great. Joanne, can I just turn the floor to you a little bit to frame where the panel is before we dive in with our speakers? Over to you, Joanne.
Hello, everybody, and good day. I'm just calling from Montreal, so I'm very happy to join you, and I really want to thank warmly the Pandemic Action Network to bring us all together again today. So yes, I'm one of the co-panelists on the independent panel, and I'm a pediatric emergency physician, and I'm actually not anymore the International President of Doctors Without Borders. I left that job a year ago. To begin, I'd like to just give a bit of a background, just a summary. But basically, the independent panel has been put together after a resolution last May at the World Health Assembly, in order to make sure that we learn and gain all the lessons from this pandemic, and to make some recommendation to improve our collective capacity to respond and to prepare for pandemic. This independent panel is co-chaired by Ellen Clark, the former Prime Minister of New Zealand, and President Sirleaf from Liberia. So they appointed 11 other co-panelists across the world, and a few of them are joining us today. I want to stress that the independent panel is independent from WHO and from people in general, I would imagine. So we have started our work since September, and then we've been working on a regular basis and meeting every if I'm not mistaken, every about 6 to 8 weeks to see, how we are progressing. Our goal is to figure out, from 3 pillars, from past experience, what can we harness from that, from what has been going on since the beginning in terms of the pandemic, in order to come up with a series of recommendations that are, I would say, practical and actionable for better response and for better preparedness. As we know, we just passed, the benchmark of a 1-year pandemic declaration. Lots of things has happened. And one of the amazing things that happened is actually coming together of rapidly developing several vaccines options. And this is such a heroic, I would say, event, and I think we seem to forget about that. But when we think back about Ebola, this is such an amazing accomplishment. Nevertheless, we're facing a lot of challenges in terms of vaccine, and we all know that the vaccine will make a difference if it is not in a freezer, but in the arms of people who need it. So we are very, very keen to hear, what are the challenges in terms of addressing this now the step from freezer to arms of beneficiaries. And so, and then we all know that there's different, I would say, consideration to be taken in to be addressed. But I know as well now everybody is following, the public debate about what's going on with specific vaccine and the confusion of some of them were safe or not safe. So I think today, the conversation is key for us to harness and understand better, what is the ecosystem around vaccine, about hesitancy, about communication, about buying, about vaccine. So we came to hear from you. The panel is really much still, although we're starting to craft some recommendation, we're in the early phase of this phase. We're still in the what we call a listening mode. So we are very, very keen to hear from all of you. And then our plan is to come up with a final report for the World Health Assembly in May. So without any further ado, I will turn it back to you, Louise, to hear about all our different guests today. Thank you very much.
Thanks so much, and thanks for being with us today. So just to set the scene a bit, obviously, as Dr. Liu said, we've witnessed both record-breaking vaccine developments and timelines, but also some difficulties related to access, storage constraints, and an alarming amount of vaccine hesitancy in rapidly shifting circumstances, and we see that all around the world. So it means that community leaders and national leaders, advocates and public health officials have had to consider many factors to ensure their populations can be vaccinated as quickly as possible. So we're really pleased to bring you a diverse and geographically diverse, as well as diverse in terms of perspective, outlook and roles set of distinguished speakers today. We're going to go east to west again around the world. And I'm delighted to welcome our first speaker, Soha Al-Bayat. Dr. Al-Bayat is the head of vaccinations with the Qatari Ministry of Public Health and the lead for the National Track and Trace team, which is a huge amount of responsibility. So we're really grateful for you finding time to be with us today. So Dr. Al-Bayat, it's over to you.
Thank you for the introduction. So it's good morning, good afternoon, and good evening, depending on where in the world you are. Thank you for inviting me, and I'm looking forward to listen to my colleagues across the world. I would like to just take a couple of minutes to just share our experience here in Qatar and how did we manage procurement or ordering the vaccines and where we reached now. How we dealt with the challenges that you guys have mentioned already. So from about exactly 1 year ago, so March last year, 2020, once the several companies started talking about them manufacturing the vaccines, we've approached several of them. We've seen how they're starting their data, etc. And we managed very early on to secure contracts with 2 of the manufacturers to supply the state of Qatar with sufficient amounts of vaccine to cover the population, of course in phases, understandably, due to the limited quantities being produced and to ensure equity across the world. We started vaccinating and we received our first shipment of the COVID-19 vaccines back in December 23rd of December 2020. And we immediately started our campaign because we had worked a few months before that to plan and prepare for it. So actually 2 days after its arrival, our campaign was launched. Yes, it was a bit of a challenge for the storage. We don't usually use minus 70 degrees centigrade storage for vaccines. So that was a bit of a challenge. But the good thing is, because we were aware about this requirement, we had months to prepare the storage before it actually arrived. And thank God we did that. And of course, there's the other minus 20 and other requirements, but that was the most challenging one to meet. When we started the rollout, as you just mentioned, the vaccine hesitancy, the rumors, the quantities that first arrived with the first shipment, the logistics, that was a bit of a challenge. But I have to say that we started off with just a few hundred per day. And we are talking here in Qatar, we are a total population of only about 3 million between citizens and residents. So we're a very small country with a small population, which could be equal to 1 city in one of the other countries. But still, that was just a very low number. People were hesitant. It's a new vaccine. People were hesitant. It's a new technology. People were listening to rumors. The world is now small due to social media and mass media for that matter. And it seems people listen to people on social media more than they listen to the physicians and scientists and the experts. So that was a bit of a challenge. But I'm happy to say that now we've reached about 20,000 doses per day. So we've started with just a few hundred, and now we are at about 20,000. We started with only 7 locations giving the vaccine, which is in our primary healthcare, and then extended it to all our primary healthcare facilities. We extended it to certain establishments that helped with the vaccination, like our military, our Ministry of Interior, to vaccinate their own people and their families. So we've kind of extended the locations that made available. We've also a few weeks ago specified a location for mass vaccination. So it's a big exhibition hall where people can come in. And of course, to avoid crowding, it's by appointments. We started our drive-through for the vaccines as well about 2 weeks ago. We are still looking for more and more areas to provide the vaccine. to make sure that we cover as many as possible, to increase the uptake per day, and to make it easy for people to reach the location, because we don't want it to be an accessible location to give it to them. And as you know, it's very difficult to do the usual outreach we do, like with seasonal influenza vaccine, due to their storage and their handling requirements for the COVID-19 vaccine. The biggest challenge was the logistics, and we managed to sort that out. Like every country in the world, shipments were delayed, shipments came not the quantities that were expected, but we still managed to give people their second doses on time. We're managing to give, and as I said, we started with a few hundred to more than 20,000 per day. I think one of the challenges that I'm sure all the countries are facing is hesitancy, lack of trust. So we had to change our methods. Basically, in the past, we used to depend on newspapers, TV interviews, using official websites to give the people the necessary information. We've reverted to using social media as well. So we've used Instagram, we've used Twitter, we've used Facebook, we've used, believe it or not, TikTok as well. So whatever means, and that's an official TikTok account, and I'm doing the videos for people where I just listen to what the people's concerns through various media accounts, and I answer them on TikTok. And I do that in English and Arabic to make sure all the citizens and residents get the information. We've even started doing a live Instagram Q&A sessions in both languages once a week. So, and we noticed that after doing that, more and more people started to get the vaccine, because now it's like a one-on-one. They're listening to us, we're listening to them, we're giving them the answers. Another thing, like many countries in the world, we had our top authority taking the vaccine themselves, being filmed and pictured while doing so. All the way, of course, from His Highness the Emir of Qatar. He himself took the vaccine and he allowed the cameras to film while he was doing that. His brothers, various ministers, and even us, the authorities and the Ministry of Health. I myself was one of the people who took the vaccine on the very first day of the campaign, and I was filmed and people saw videos and pictures of me taking the vaccine to just tell them we're practicing what we preach. We're taking it and we're fine. Even the second dose, because people were hesitant. So I do think it's a big challenge all across the world, but I think we need to be innovative in our ways, be it from the way we're administering the vaccines, from the way we're reaching out and giving the information to people. And I guess the main obstacle here is so far, shipments have been coming. We've faced a few delays or lesser quantities, but it hasn't absolutely not put any obstacle in our ability to vaccinate. And we're receiving them, but of course, like the rest of the world, in phases. I think we're doing good. I think we're progressing well. Still, we're facing some hesitancy, some distrust in the technology for the vaccine. So I'm looking forward, if our colleagues in the panel have faced similar issues, how did they deal with it? From my side, I just shared what we did, and I look forward to listen to the other panelists. Thank you.
Thank you so much. That was great. Wonderful to hear from you. We're going to travel south and west now to Liberia. And I'm very pleased to welcome Rustin Yanako, Director of the National Community Health Systems with Last Mile Health in Liberia, who oversees the organization's partnership with the Liberian Ministry of Health to deploy health workers in every remote community in the country. So thank you for being with us today, and it's over to you.
Thank you so much for having me. I'm glad to be speaking today about immunization, which is one topic that I'm very passionate about. So as Last Mile Health Director of National Community Health Systems here in Liberia, I've had the opportunity of working closely with the Ministry of Health as it relates to developing a clear COVID-19 vaccine deployment strategy. One key area that we have been focused on as it relates to the COVID-19 vaccine is the area of effective communication. And this is because misconceptions and misperceptions spread so quickly and would serve as a major roadblock in the delivery of quality health services. In Liberia, we have like about 70% of our population that live in rural areas lives beyond 5 kilometers or 1 hour distance from the nearest health facility. And that shows that most of those people don't have access to basic internet, they don't have access to newspapers or even radio. And so most of them really depend on information from one person to the other. Most of these people travel to urban areas to do business transaction. And when they come back in the community, they bring in information. And so through the kind of mode of communication, you find out that misinformation really spread widely and very fast. And they are often very difficult to dispel. Before the arrival of the COVID-19 vaccine in Liberia, there have been several incidents of rumors and misconception being spread about the negative effect of the vaccine. And that was actually because there have been this misconception that Africa was being used as a ground or testing ground to test the vaccine globally. And this was really taken seriously in many quarters of our communities. And that started to lead to some fear and led to some level of vaccine hesitancy, even affecting our routine immunization program. So we decided to act proactively. And if you look at new polls that are coming up, it starts to show that there's this chronic mistrust in government when it comes to the vaccine rollout. Over half of the population in 5 West African countries, including Liberia, said that they did not trust government to ensure vaccines were safe. In Liberia, quite recently, like a week ago, one of our primary news outlets, Front Page Africa, took a story and highlighted how some European countries were already halting vaccination, especially AstraZeneca, which we have here currently in country. They were halting it in those European countries due to fear of blood clot. That has had its own impact on how we communicate about the vaccine across the country. So about a week ago, about 96,000 doses of the AstraZeneca vaccine arrived in Liberia, and we announced the arrival officially. But now the issue about combating vaccine hesitancy is really, really critical in this point. So we were able to work with the Ministry of Health to develop a formal communication plan on how we thought that we would address these misconceptions and myths consistently. And we thought that one key pillar in addressing those myths and misconceptions was using existing community health structures. Community health workers were actually an essential part of those plans, and their role was actually providing health education, providing vaccine education, especially because these community health workers live and work in communities. They work with their neighbors, their relatives, their friends, who look up to them for sharing health-related information. So we thought that that was an excellent platform to begin with. But in addition to that, to be really effective, we thought that community health workers needed to be trained and protected as well. So we needed to provide continual clinical education materials to these community health workers to keep them informed. We all agree here today that COVID-19 still have a lot of changing dynamics. So we need to keep these community health workers updated with best practices and protocols. So as we train community health workers to deliver effective vaccines education, we also think that that will be an excellent platform that we can use for the delivery of vaccines and other immunization-related activities, even beyond this pandemic. So we have highlighted a need to prioritize community health workers during this vaccination campaign. And that will ensure that we are not putting community health workers at risk, making sure that they are safe. But beyond just making sure that they are very safe, we think also by immunizing community health workers first will also create improved trust and reduce vaccine hesitancy, because they will serve as testimonials that the vaccine are safe and are effective. Liberia today is able to rely on a very strong network of community health workers for vaccine education. The community health workers proved very vital when we were combating Ebola a few years ago, and they have also proven very instrumental in the initial fight against this COVID. So if we are to meet our goal of ensuring that safe and effective COVID vaccines are available for everyone everywhere, we think that community health workers are our best option. Thank you.
Thank you so much, Rustin. Thanks for being with us today. That was great. We're now going to move to Nigeria, and I'm very pleased to welcome Atahir Abubakar, who's the technical assistant for the National Primary Healthcare Development Agency in Zamfara State in Nigeria, and has been supporting the vaccine rollout there. Thanks for being with us today, and it's over to you.
Thank you very much. Good morning, good afternoon, good evening, depending where you are. Thank you very much for this opportunity. In Nigeria, the COVID vaccine has arrived. Our 3.95 million doses has arrived the country. The AstraZeneca Oxford brand, which was distributed across the country, and most of the prominent people, even our president, Muhammadu Buhari, and his vice president was seen publicly being administered the vaccine. So in the whole 36 states in Nigeria, it is only one state, Kogi State, that did not accept the vaccine. And in all of those states, the key personnel, key executive people in the states were part of those that were administered the vaccine first. Even me yesterday, I was able to collect my first jab of the vaccine. The main challenges that are currently facing this vaccine rollout in our country is the hesitancy and the rumor filtering in from Europe that the AstraZeneca vaccine is causing blood clotting, low libido, respiratory distress. So this news that is filtering from Europe is one of the key challenges we're facing. Even today, I think I received like 6 to 7 phone calls from colleagues that knows that I get my first jab yesterday, asking me, how are you feeling? I told them, I'm okay. There's no any reaction. I'm feeling no any change in my physiology. So I don't think it's one of the challenges. The information from perspective, what we need to do now is, as said by a colleague now from Liberia, we need to equip our healthcare providers with up-to-date information on the COVID vaccine. Recent researches need to be published, shared with healthcare workers, digest it for them to understand, because they are the one being faced with reality. People are attacking them. Then another aspect for me in Nigerian context, we need to involve the religious leaders. Religious leaders play a key role in vaccine acceptability in our country. If I can remember, during the polio pandemic, polio vaccine in the early 90s, where people rejected the vaccine completely, we used the religious leaders and we're able to penetrate most of the communities, and we have reduced the hesitancy to a minimal level. Though we can't say all people have accepted the polio vaccine up to the time of the eradication of the polio vaccine. What the religious leaders and the traditional leaders has played a critical role in mobilizing community, diffusing the hesitancy of the vaccine. So now we need to engage them. Though there is a risk communication message that has been developed by the National Primary Care Development Agency in respect of this hesitancy. On a daily basis, they keep on countering those messages filtering from Europe on AstraZeneca vaccine. So on a daily basis, the National Primary Care Development Agency, who has been saddled with the responsibility of delivering the COVID vaccine, are on top of the matter in collaboration with some partners. So those are the issues we are facing. Hesitancy regarding the vaccine. Yesterday, I was listening to a radio program where a member of the House of Assembly was answering questions regarding the vaccine hesitancy, because together with me and him collected our first jab. One person was asking me, now you that collected this vaccine, if you die now, what will you say? Because this vaccine has been declared non-potent in Europe. So why are we accepting it in Nigeria? So we have to try to diffuse this kind of messages. Then some people are saying, someone asked me categorically, we have malaria that has been disturbing us. We have hepatitis that have been disturbing us. Why is it that there's no vaccine? That quickly within a year, vaccine for COVID has come up. Is that there's no protocol that they are following, or are they abating the protocol? Because he's a scientist, he knows that developing a vaccine has to follow a peculiar protocol that needs to be adhere. And from stage A to B to C to D up to the final conclusion. He mentioned it to me too. Then what happened that AstraZeneca were able to scale through to reach this, and now we are having these issues in Europe and other part of Asia. So I was able to convince him that even the common paracetamol you are taking has a side effect. What the side effect will do in person A may not be the same that will happen in person B. So there's individual difference in the physiology of human being. So it will not be the same. So as a final note, the major challenge now we are facing is the rumor filtering from Europe. As a Bush community member, I received a lot of support from my colleagues, which were able to provide me with information. I even contacted Toma in Geneva, some other person even in Liberia and Cameroon. How are they working so that we collaborate in order to dose this tension and this tension of COVID vaccine hesitancy in our community. So the Bush community was able to provide a platform for me to liaise and network with other colleagues in Africa, Europe, and even Asia, so that we can have a common ground in country so that we can reduce this hesitancy and increase acceptability of the COVID vaccine in Nigeria. Thank you very much. Over.
Thank you so much for that, and very strong key message and understood. And it's so interesting to think, although we understand that vaccine education and vaccine hesitancy always needs to be tackled locally, obviously there's this huge global dimension as these rumors travel between continents and are often created, some of these problems being created in Europe, for example. Thank you for that. We're now going to hop back to Liberia, to Adolphus Clark, who's the manager for the expanded program on immunization with Liberia's Ministry of Health. So Adolphus, thank you for being with us today. Over to you.
Thank you so much. Trying to get the name, but yeah, I'm looking for the name. But anyway, let me see. Thanks for the. Okay, oh, Sama. Sama, thank you, dear. Thank you so much for the opportunity. And let me say good afternoon, good morning, good evening to all, depending on your time zone. I know that for some of us, this afternoon hours, but now while for others it's still morning hours. With that being said, I just like to provide update on where we are today relative to COVID vaccine deployment in Liberia. And if you allow me to go back in time a little, Liberia, we received our first batch of the COVID-19 vaccine March 5th, 11:17 p.m. A total of 96,000 doses arrived in Liberia at about that time. And prior to the arrival of the vaccines, there have been ongoing engagements with relevant actors to ensure that we can get the desired uptake for the vaccine, because we've realized that April of 2020, this issue of mis and disinformation in Liberia took center stage, which negatively impacted our vaccination coverage. So being cognizant of that fact, we thought that it was extremely important to start behind the scene engagements with relevant actors to ensure that we can get the kind of political buy-in that we want, that will subsequently increase the uptake of the COVID-19 vaccine in Liberia. As it stands, we are still in our planning and preparation phase relative to commencing the first inoculation in Liberia. There will be tomorrow, there will be another engagement, high-level engagement. We had the first high-level engagement last week with the Parliament of Liberia, or the National Legislature of Liberia, informing them on the vaccine, what we know relative to the science, and what we think we need to tell them given all of the pieces of information available. So that engagement meeting was held with the National Legislature. tomorrow we'll be holding another engagement meeting with the cabinet members in the executive branch of government, which we think that is extremely important given the recent development of the vaccine, so to speak, AstraZeneca. We think that it is important to provide further information to cabinet members on where we are, what our strategies are as it relates to safety, safe monitoring, and what mechanism we have in place to be able to respond to any safety concerns. So this engagement will happen tomorrow, at which time we look forward to getting further support from the cabinet in terms of endorsement to proceed. We have hoped to commence our vaccination exercise tomorrow, but owing to the fact that there will be cabinet meeting, we can't say at this point in time when will be the next launch date. We look forward to hearing from the cabinet members in terms of allaying their fears, addressing their concerns, what they need to know, what we know, so to speak, about the vaccine, and what are those things that should be happening. We continue to engage our healthcare workers in terms of capacitating them. So this afternoon at about this time now, we are having training for about 25 healthcare workers in Liberia, capital to be precise, that will form part of the vaccination team to begin the rollout of COVID vaccine in Liberia. So we are providing them all of the facts that we know about the vaccine, how to respond to the current situation happening in Denmark and other European countries, what they need to know to be able to engage caregiver or clients who may show up at the vaccination post to access the COVID-19 vaccine, because there will be a situation where people may likely just show up for the vaccine because they want to test the system in terms of what you know about the vaccine, how you can relate to them or convince them in terms of the cost-benefit analysis of the vaccine versus the risks or the mis and disinformation that we have permeating the media. So we think that it is important that we give them all of the information. Tomorrow we'll be engaging the professional bodies again, given what WHO has provided to us through their official website about the AstraZeneca vaccine situation in Denmark and other European countries. We will be again sharing with our professional bodies what we know and why they need to trust the system and believe in the vaccine that we have in country in complementing other IPC efforts as it relates to COVID control and prevention. So these are just summary in terms of where we are. We are continuously working to further strengthen our supply chain system to ensure that once the vaccine moves from the national vaccine store, we are able to keep the cold chain intact until inoculation takes place. So there are multiple tasks at this point in time happening behind the scene, ranging from vaccine confidence, safety concerns or safety monitoring, logistics, service delivery. So there are a couple of things that we are doing that will enable us to be able to deliver the vaccine in time. Over.
Thank you so much. Thanks for that. And I just wanted, before we move on, just to acknowledge that Preeti Sudan, another panelist from the independent panel, is also on the call. So welcome to you. It's great to have you. Thanks for being here. And I'm delighted now to hop over another ocean to Argentina to welcome Representative Gisela Scalia, who is a Congresswoman for Argentina, and she serves as UNITE's Regional Chair for Latin America and the Caribbean. Gisela, thanks for being with us today. Over to you.
Muchas gracias. Buenos días a todos. Thank you. Good morning from Argentina, good evening and good afternoon. We are here after a very unusual 2020, a year defined by vulnerability and uncertainty, a year where everything changed due to the new coronavirus, a year that turns our lives upside down and that forces us to assume unknown perspectives, a year that reminds us the importance of caring for others. We live in troubled times. We are following live, so to say, the development of new vaccines against this new infectious disease that bring us hope in science, and hope that one day this pandemic will be over. In our nations, we are an important voice to call for the immunization of healthcare workers and those at highest risk of being infected with COVID-19, the elderly, education workers, people working on site, and so on. In Argentina, the situation is more worrisome. 3 weeks ago, our former health minister was forced to resign amid the VAP COVID vaccine scandal. It all started when a well-known local journalist said he had received a vaccine shot preferentially after requesting one from the minister. And that was only the tip of the iceberg. Mayors, congressmen, and women, activists, and people close to political power received vaccine shots despite not being in the priority group authorized to receive them. Yes, as you can hear it, no more and no less that vaccinations of privilege for politicians and their relatives and friends. I am not the first one to point that President Alberto Fernandez's government has organized a very slow vaccination operation in Argentina. One of our neighboring countries, Chile, has vaccinated 1 million people a week since February 3rd, around 5 million doses, while Argentina has administered only 2 million doses. And that is not to mention the huge difference in terms of total population. Argentina has 46 million people and only around 4% of them were vaccinated so far. Chile, it's now not only a regional but also a world leader with 33% of the total population vaccinated. In Argentina, the acquisitions of vaccines is centralized, and so it's the internal distribution. There are no internal inequities, and every province is having its shares of doses and organizing vaccinations campaign following the guidance of the National Ministry of Public Health. Of course, let me repeat that again. During the VAP COVID vaccine scandal, no priority groups or guidelines was followed or respected. The lack of transparency, the difficulties in our intergovernmental mechanisms, and the absence of pandemic preparedness put our government in a vulnerable and difficult situation for the access to vaccines and the immunizations of our people. At the Congress, we are in the middle of serious disagreements and thought debates. Is the government purchase mechanisms efficient? It's necessary to rethink the role of the private sector in the purchase of vaccines, such as private health insurance, NGOs, etc. Those are some of the questions we have to ask and we have to put on the public agenda. In Argentina, as in many Latin American countries, we have to change the existing law. We have to adapt our legal framework in order to be able to make a massive purchase of vaccines. I do not want to forget to mention another obstacle in Argentina. The first vaccines available for us was the Russian vaccine. Unfortunately, the producers of the Sputnik 5 had not finished the phase 3 trial, not published and concluding result. As you can imagine, that was a problem to build vaccines confidence. And now I'm happy to share that Sputnik 5 vaccines has gained acceptance, especially after the article published in The Lancet at the beginning of February this year. We have now different vaccines available from different producers. We know that many factors influence vaccines decisions making. We have to keep working hard in building vaccines confidence, and clear and complete information is a major step forward on the way. So today, I'm here to say no to inequality among nations or citizens, no to privilege. This pandemic will be over if we fight together for equality and universal access to health services. I'm very positive about it. The future of humanity lies in connections, solidarity, and cooperation. So I want to call you to remember the importance of being there for others. It is time to create networks and to share our knowledge. It is time to invest in pandemic and epidemic preparedness. So congratulations for this event and thank you for your kind invitations.
Thank you so much, Representative Scalia. It's really great to have you and have your perspective and insights from Argentina. We're going to head north now to North America to welcome Malcolm Glenn, who's the Director of Public Affairs at Better.com and an advisor for the Health Action Alliance. Malcolm, we're really pleased to have you. Over to you.
Thank you, Eloise, and thank you everyone for the opportunity to talk with you a little bit today about what we're doing. As Eloise mentioned, I work at a startup called Better.com that's based in New York City, though I'm in Washington, D.C. And I've also spent a number of years over the past decade focused on equity-driven issues at a couple of other global companies, including Google and Uber. But I'm largely talking to you today in my role as an advisor for the Health Action Alliance, which you can find at healthaction.org. And the Health Action Alliance is a coalition of businesses and public health organizations and foundations that work to promote vaccine awareness and education through business leaders. And what we do is we create materials, we host events, and we really try to provide a playbook to help businesses of all sizes communicate with their employees and their customers and anyone else who might be affiliated with that business about the importance of vaccines, as well as we work to try to increase adoption of those vaccines as they become more widely available. My experience is largely in business and in the private sector, and it's really helped inform the way that I've approached my work at the Health Action Alliance. At Google, I was on a team of people that were focused on employee communications, and I was specifically handling those communications from one of our senior executives, our chief financial officer. And through that work, I learned a lot about how to figure out which communications truly reach employees, particularly at a large company where they're hearing from lots of different sources every single day. What spurs them to actually take action versus reading an email and moving on to the next thing on their plate, as well as which mediums we can use to effectively get the word out. And then when I went over to Uber, I was really focused on equity-related initiatives, working specifically with external issue groups and advocacy organizations and nonprofits to find ways to use the platform to connect people to the opportunities that they needed. And so the Health Action Alliance is a combination of those things, working to inform employees about vaccines and education, and also working with external partners to make sure that, if possible, we can utilize the platform that we have in order to get that information out into the right people. And this is all really important, particularly in the United States, because there's data that actually shows that here, people actually trust information from their employer more than they do from their elected representatives. And so there's a real opportunity, particularly depending on what type of business you are, for leaders in the private sector to have a really strong role in creating a plan to help communicate with their employees about why vaccines are safe, why they're effective, and then importantly, providing access. So giving employees time off to get the vaccine, giving employees time off in case they have side effects, as well as, when possible, providing incentives to employees to maximize vaccine adoption, and optimally, in a lot of cases, helping get business operations back to normal. And so there are a few key ways in which we've been working to kind of inform our campaign based on what we've learned from other campaigns in ways that we think are going to really increase vaccine adoption. And I'll just go through a couple of those now. So first is, it's really incumbent upon businesses to plan for this early. We started this conversation at the beginning of February, even though in the United States, most people were not yet eligible to get access to one of the vaccines. What we've learned over the last couple of months as our president has moved up some of the deadlines around when he expects all adults to be able to be eligible is it's important for businesses to plan early. A lot of businesses were expecting that it would not be until July or August or even September until all adults in the United States were going to be eligible to get the vaccine. That date has been moved up to May 1st. And so it's really important that businesses are planning for when their employees are actually going to be eligible and helping inform them about how they go about that process once that eligibility takes place. And there will of course be people who need to be convinced to get the vaccine or who will still need more education. So the earlier you start that process as a business leader, the more likely you are to increase adoption and increase education across your workforce. And I think it's really important that a plan account for everyone in the workforce. And so here in the United States, we have lots of different worker classifications. So some people are full-time employees, some people are part-time workers. And then we have a lot of companies that bring on people as temporary workers or contractors. The plan should account for making sure that all of those people are getting the education and all of those people are getting the access as well. Second, I think it's really important that, if companies are going to provide incentives, that they're really thoughtful about how to structure those incentives. And so there are a number of companies in the United States that have already said, we're going to give you, a small monetary stipend, perhaps, if you go and get one of the vaccines. We've actually seen some research that shows that if employees feel like there's too much of a monetary incentive, then that will actually deter them from wanting to take the vaccine. They start to question whether the employer has the best interests in mind. They say, why are they trying to coerce me into doing this? And so what we've encouraged businesses in the United States to do is, as they think about incentives, it's really important that those incentives be modest, if they exist at all, and they should not be sort of existing in a vacuum. They should really be tied to facilitating access. So some companies have said, we're going to give you, a couple of hours off to go get the vaccine, or we're going to give you the rest of the day off if you have side effects, or we're going to pay for you to get transportation to and from the vaccine site. Because as a number of people already today have mentioned, there's certainly a lot of vaccine hesitancy, but there's also vaccine access issues. And some of the communities in the United States for whom there were early conversations around potential vaccine hesitancy haven't been particularly hesitant. There have just been challenges in terms of access. And so tying those incentives from an employer perspective to removing barriers is really, really important. And it's less likely to make your employees think that there's some nefarious interest in why the business is trying to encourage people to get a vaccine. Third, I think it's really important that businesses make sure that they understand their local context. Again, this is something that a number of folks have talked about today. And that means carefully reviewing the state and the local vaccine plans in the United States. Every state has a different plan for how eligibility is determined. So some states are already opening up vaccine eligibility to every adult. Some states have age requirements. Some states have age requirements as well as other medical requirements. So it's really important as a business that you understand your local context, and making sure that if you're a business that operates in multiple jurisdictions, you recognize that you might have a different communication strategy for some employees than you have for other employees. And finally, it's really important to highlight the stories of people who have received the vaccine and who have had a positive experience. When what we've determined is when you see your colleagues responding positively to this, it's more likely that you're going to respond positively to this. I can tell you about my own personal experience in this respect. In my workplace, I shared with one of our employee resource groups, which are groups that represent certain demographics of employees at the company. I shared with our employee resource group that I was actually a participant in one of the vaccine trials. And I recently learned that I've actually been vaccinated since last fall. And it was really powerful to share that experience with other team members and other colleagues. It really helped people who were a little bit on the fence about whether they were going to be one of the first people to get the vaccine when they were eligible. It helped them put a real human and personal face behind the vaccine, someone they knew and someone they trusted. And so knowing whether employees are more likely to be vaccine hesitant or simply just lacking access is a really key distinction. And so for some communities, of course, education and awareness will be really, really important. But for other communities, again, it's about making their access to the vaccine easier. So lowering those barriers of entry by again, providing time off or paying for transportation is really, really key. And so I'll just end by saying we know that the challenges for different businesses are very, very different. And so many businesses, particularly small businesses, won't have the capacity or the resources to provide an incentive. They might not be able to give every single one of their employees time off, particularly if people are getting the vaccine at the same time. And so we have resources to help businesses, depending on your size, understand how you should communicate around the vaccine and what type of structures you should put in place. We've already developed a number of really valuable small business resources. We have a quick start guide for anyone in the business community who's looking to create a plan around vaccine awareness and education for their employees. And so you can find all of these materials as well as a ton of other resources around how to effectively communicate with any audience around vaccines at healthaction.org/resources. And again, our main website is healthaction.org. And hopefully some of the resources there will be helpful to you in the various situations you find yourselves in. I'll stop there.
Thanks so much, Malcolm, for that rich intervention. And our own colleague led some research into vaccine hesitancy, and the overriding conclusion was really what you just said, that the easier you make the rollout, the more you can combat hesitancy. So while it's tempting to separate the logistical from the emotional, actually all of this is much more intertwined, I think, than we, our heads tend to silo things before we even start off. So thank you for making that really important point. I'm going to turn now to our closing speaker. Last but certainly not least, we're going to the northwest of the US now, and I'm really pleased to welcome Cristina Toledo Cornell, who heads public health at the Lummi Nation in the northwest of the US. Cristina, thanks for being with us today. Over to you.
Thank you so much for having me. Very exciting to get to see all of you around the world. I am working with the Lummi Nation here for the last 3 years. The Lummi Nation is a tribe in the United States in Northwest Washington. It has an enrolled population of 5,200 people, but it serves a much bigger community because we also serve, as part of our service population, other Native Americans living in the area. The Lummi Nation, like many have said, had a ample time to prepare for distribute these vaccines in a ways. It started by partnering with the University of Washington to run a clinical trial. So like our colleague from Qatar mentioned, we were able to set up all those infrastructure, cold freezer, that kind of thing ahead of time. As we initially started getting vaccines, it was a small amount, like most people, and distributing them in a more conventional way, making appointments, that kind of thing in the clinic, and rolling them out to the priority groups. The Lummi Nation is able to set up its own public health infrastructure because it's sort of an independent entity, being a sovereign nation within the United States. So it has its own infrastructure, it sets its own priorities. As we roll this out, though, we got more and more vaccines, so we're able to expand greatly our reach, and has been now focusing in doing large vaccination campaigns, like here in other places in the US, just making large clinics and opening that up quickly for anyone who is registered with our service population. as we roll this out, also the Lummi Nation realized that it also wanted to vaccinate other individuals who interact with the community, be it teachers for the school, other services provider that are in service in our service area. So it has been able to also vaccinate other individuals around the community. But like many others are saying, we do struggle a little bit to vaccinate the vast majority of the community, in part because Native Americans in general has had a tough time with the healthcare system, particularly the concern that they were used as research subjects, that kind of thing, in the past without their consent. I think that some of the work that we've been doing from the beginning, including have a clinical trial, having a lot of those discussions, has eased a lot of those concerns from some of the community members, and those have easily been vaccinated. However, there's a big chunk of the community that still haven't accessed yet the vaccines, despite the fact that we have more availability of vaccine than most other communities in the surrounding area. And that group of individuals, including mostly younger people who particularly those that don't access healthcare very often. So there's a lot of concerns that they're perhaps being used as research subjects without their consent as well. The word that Lummies use a lot is that I don't want to be a guinea pig. So there's a lot of those concerns. We have been working very hard to sort of decrease some of those barriers. One of them also is that just as a community in general, there is a greater degree of poverty as compared to the surrounding community. For example, a lot of people don't have transportation, access to the internet, so they not always know when those events are happening and how to get there themselves if they do know it is happening that day. So those are barriers that still have to be overcome. When I talk to other Native American tribes in the area, a lot of those same barriers are still in place, despite the fact that, again, most Native American communities have luckily been having better access to early vaccine distribution as a priority group for the United States government. So our biggest now challenge, I guess, in many ways, is to really get those communities vaccinated, those that are really hard to reach and those who are really hesitant about getting the vaccine. And working as others have said with religious leaders, community leaders, elders, those that are mostly are respected in the community to really offer the vaccine and combat some of the misinformation that's out there. I spend a lot of my time as a physician helping people understand the safety and why it's important for them to get. So all of those things are playing out as we hopefully trying to vaccinate. Having said that, we're probably about 50% or so of vaccination of the community, which is higher than most other communities. So that's still very positive, I think. And then finally, the other part of this is that I think, like Malcolm was saying, that considering incentives for those harder to reach group is a big deal because sometimes it just takes a little incentive for people to say, well, I'm taking time off from my work, or I'm not going fishing today. I should have some sort of compensation or some sort of incentive to make that decision a little easier for me. As we were running the clinical trial, for example, some people volunteer even though we mentioned what we are getting vaccines very soon, you can wait. They said, no, I really want to do this clinical trial. And I think part of it is that they do have a small amount of compensation for their time, for the work that they're taking, and the timing that they are spending to do these vaccinations, particularly because with the way we are currently doing, it takes a little time. Sometimes you have to wait in line for a little bit because we have decided that scheduling appointments just is one other barrier for people to have to go through and get those appointments in the book. So overall, I think it's very positive, but I think there's quite a bit of work to do. And again, as we get more vaccines and more people vaccinated, I hope that those barriers become less of a problem, that people become more confident that the product is safe and that they will protect them and their communities from the COVID-19, which really has hit us really hard at certain points when things were really bad here. We had more than 10% of all the cases in the county, and we are just like maybe 1% of the whole population, not even that. So it hit us really hard. But again, I'm hoping that we continue to roll those and encourage everyone to be vaccinated.
Great. Thank you, Christina. Thank you for those insights. Really fascinating. And once again, I think this tour of the world, Christina was our final speaker before Q&A. So I'll just let you get your questions together and have a think about that. And what's really striking is while there are obvious differences and local community aspects to bear in mind, there's also a lot of interconnection in the digital age, with rumors spreading across borders, similar themes coming up in very different places and contexts, whether it's about the fear of being a guinea pig, as Christina described, general safety issues, the incidents of the confusion in Europe about the attitudes to different vaccines spilling over into Africa and other places, and other rumors about health. There are a lot of synergies and a lot of common challenges. And I think it's great that Malcolm, for example, shared in the chat the resources from healthaction.org. And one of the things we're hoping to do at the Pandemic Action Network is to help share vaccine hesitancy materials and help adapt them for different contexts. So that's just a word on what we're doing in future while you get your questions ready. I just wanted to point to a question that's in the chat from Jerry Martin that says to our Liberian friends, Rustin and Adolphus, how does Liberia's experience with Ebola make COVID vaccine distribution easier or harder? So if you could just be cogitating on that, and I'll also go to Michelle for reaction and a question, and then come back for some answers. Michelle, over to you.
Thank you very much, Eloise, and thank you to all of the speakers. I have two questions, actually three. The first question is, there's one word or one name that I haven't heard from anyone, and this is WHO. And it looks to me like for each of you, the issue we're discussing is a sort of single dialogue between the authorities in the country and the citizens, the communities. But WHO, which we have seen as a panel, publishes one guidance note a minute since the beginning of the pandemic. WHO, which is present at regional level, and WHO, which is present in every country. I'm surprised that you're not mentioning how you're interacting with it, or are you not interacting with the agency in any way as you set your strategies for vaccination and for building vaccine confidence. My second question is, everyone has emphasized the need to work for increasing vaccine confidence. What strikes me is that there's no visibility on vaccine availability. And therefore, as you increase your efforts to help gain in vaccine confidence, aren't we also taking the risk somewhere? And how much do you feel there is a risk that people will actually become anxious as we see the gap increasing between coverage and actual need for coverage? I didn't get from anyone a clear message of what the strategy is. And I personally haven't seen an overall global strategy. The strategy seems to be, our colleague from Argentina clearly said, healthcare workers and people at higher risk. But otherwise, the strategy seems, let's vaccinate as many people as we can. I don't know how much this is strategic and whether this as I said, since current projections are that vaccines will not be there in full coverage until 22, 23, maybe 24. How manage the gap between expectation that we're building and reality of coverage? Sorry for being long. Last question, very short, to our colleague from Qatar, Soha. I realize, that Qatar has secured amounts very early on, but what do you think for a global world? Is this sort of wild market where everyone rushes to secure access to its own population is the way to go? What would be your suggestion for a better system than just free wild market forces? Thank you.
Thank you very much, Michelle. Lots going on in those pertinent questions. Can I ask whether Adolphus, our friends in Liberia, Adolphus or Ruston, have a reply?
Yes, yes. Okay, so thank you. If I got the question right, it has to do with what lessons are there from EVD that I'm just trying to do a summary that can help propel the uptake of COVID-19 vaccine in Liberia. Is that the question?
Question was, did the experience of Ebola vaccine rollout help with your experience? Is it helping with the experience of?
Okay, so yeah. So that's why I summarized. Now, what we are seeing today in other parts of the world is no different from what we saw in 2015 when we had the RVSV in Liberia. Now, what lessons we've learned from the use of the recombinant vesicular stomatitis vaccine produced by Merck is that wide range consultation is extremely important at the lower level. If you are able to go down to the lower level where you establish ownership and action, uptake of the vaccine is assured. So some of the things that we started doing as an in-country team is to start the conversation with all of the relevant actors. Like I said in my intro, we met the national legislature. We will be meeting the executive tomorrow in cabinet meeting through the Honorable Minister of Health. We are planning to engage the judiciary. But beyond those, we are having community engagement meetings. We are talking to influencers. We've started engaging the religious community. We started engaging the traditional leaders through our local governance structure. So we think that what Ebola taught us from the vaccine administration is very helpful in preparing us to ensure that we don't get or have a repeat or reoccurrence. And that's why we are taking these steps or approaches to ensure that all of the relevant actors, they are brought on board and we can have all of the facts or what we know to date about said vaccine made available to them before the start of the campaign, because it's very, very important. If you don't do that, people will stay away and you give room for this and misinformation to thrive over a long-term period. So what we are doing now, we know that we received the vaccine in country on March 5th, and everyone may or might be eager to have inoculation ongoing. But what is also very critical is that if we are not strategic, this could be a moment that could either break the immunization program or make the immunization program. That's why we're having wide range consultation. We're engaging all of the relevant actors to ensure that everyone is brought on board before we start. Over.
Great, thank you. There's also, I'm going to go to Soha, unless, Ruston, did you want to come in on the Liberia point? No.
Yeah, so I could just buttress Adolphus' earlier comment. by saying that in addition to just collaborating with key stakeholders, we also realize that the data collection system or process is also key. So during the Ebola outbreak, we noticed that there were delays in report coming through, especially from the community level, and it actually impacted the timeliness of decision making or how responsive we were to most of these most of the conditions that were emanating from the community level. So now there are ongoing conversations on how to ensure that instead of using paper-based form to collect data, how can we now digitalizing our data collection process through like the Kobo Collect system, where as we get these data that comes from immunization in real time, it could inform us to make a real-time decision. During the Ebola outbreak, I think one thing that happened was that most often policymakers and decision makers are always delayed in actually acting or making a decision around some of these processes. So once we're able to get these data coming in, like in real time at the national level, from the community to the national level or the county level, which is the subnational level in Liberia, that could help us also to be able to make an informed decision. And then finally, like he also alluded to, starting from the grassroots level, we post Ebola, we have already been able to create these community health structures. So these community health structures are structures that are working directly at the community level that include influential community leaders, traditional leaders. And these are structures now we are not going to reinvent. They are already there, they have been working. So how can we now just work with them to ensure that not only send through messaging, but also be able to ask them to support the process of timely delivery of these vaccines. So I just thought to add a few points to the points that was already alluded to. Over.
Thank you very much, Rustin. I want to go to Sohan now, and also to, you had your hand up before Michelle asked the question, but I'd be grateful if you answered Michelle on that point. And I would also point all speakers to some of the questions in the chat. One on funding issues and how could they be overcome, on indemnity for vaccine suppliers, and on strengthening health systems for future threats. So please have a look there, and I'll, in the meantime, round up some answers to Michelle's pertinent questions. Soha, over to you.
Yeah, actually, I did raise my hand in the beginning just to address the first 2 points from Michelle, and then he asked the third question, which was addressed to me. So yeah, I'll start then with the question. I think it's a matter of lessons learned. COVID-19 may be a little bit slightly different than previous pandemics, but it's definitely not the first time. And where we faced cases or viruses that required development of vaccine in a short time and how to distribute it. H1N1 was an example of this. So for us at Qatar, it was a lesson learned, because during H1N1, at the beginning, when it was a standalone vaccine before it was incorporated with the seasonal flu vaccine, the world faced a shortage. And we were no different than them. And it was very difficult to purchase and order and get quantities required to meet the demand. So the minute the COVID-19 situation also arose, it was a lesson learned. So we planned very early on. So the minute talks were about vaccines being developed, we started discussions as well. And my answer also include the point that you made a comment about, which is WHO. So we spoke to WHO, we spoke to Gavi, we spoke to SAGE, we spoke to many institutions, we spoke to the industry itself, which is the vaccine manufacturing industry. And that helped us pre-plan, that helped us to be ready. And what we did is when we secured contracts, we also asked them, what do you think the requirements would be? So early on, we were told about the storage requirements, the cold chain requirements, that all helped us to pre-plan. So I will have to say that many countries planned well ahead of time. Some were a bit delayed for various reasons. It could be economic, it could be political, it could be war, it could be so many different reasons. But to us, I think planning ahead of time we learned lessons from previous situations, health or otherwise, that we need to be ahead of the game. Let's put it this way. We need to pre-plan. We need to meet every possibility. There were no guarantees we'll get the quantities we agreed on, but we still took the chance. And that's why when we were asked here in Qatar by the population here, why did you make contracts with two different companies at the same time? Our response was there was no guarantees. Maybe one company would be able to deliver, the other one would be delayed. So this way we ensure we get sufficient quantities. And we understand due to the global demand, it cannot, of course, be delivered all at the same time. Plus logistics, we cannot get such large quantities at the same time. So we plan the storage, we plan the phases of arrival of these stocks. So I think that's one way where you can ensure getting the vaccines. Other thing, and I think it's a sense of not just local sense of social responsibility, we all have a responsibility across the world. We all vary in economic status, finance, income. And I think if countries with a higher income bear in mind when they're doing plans to assist countries with a lower income, which is what to ensure equity across the world, that would be very helpful. And that's something we did plan for in Qatar, where how can we help countries that may not be able to purchase quantities of the vaccine, and how can we assist? So if countries plan ahead, be ready, learn from previous situations, and not only think about themselves, think about the entire world, because it's useless for us to just protect our country, forgetting about the other parts of the world, because if they're not protected, this will continue. We're part of the world. So I think if we think and plan ahead and think of other countries and assist as much as possible, that way we can see at least, maybe not exactly equal, but at least a fair distribution of the vaccines across the world. And as we all know that in manufacturing these vaccines, the world came together by funding, by support, etc. So I think if the world comes together again for the distribution, then we can ensure many countries, if not all, get at least some quantities for their population. So I hope I've kind of addressed your question, Michelle, for point one about the WHO and the interaction, and we're still monitoring and having discussions, as well as how do we ensure quantities and distribution, not just in Qatar, across the world. Another comment you made was about that it's all about raising awareness, uptake, and what would happen if you don't have enough vaccines, and you've now made people eager to take the vaccine, but you suddenly don't have stocks. We actually have our vaccine campaign planned ahead of time, knowing that we will not get the vaccines all in one lump sum, that we'll get them into different, let's say quarter one, quarter two, etc. So we planned our campaign in phases as well. Our phase one included people above age of 70, people who are frontliners, so healthcare workers that were working in COVID facilities, and those with severe chronic illnesses. Then we dropped down the age group to 65, then to 60, and recently we dropped the age group to 50. So every time a new stock comes, we widen our phase of the campaign. And the same thing even for the healthcare workers. We first started with those who are at most high risk of contracting it due to their actual work at a COVID hospital. Then we started to widen it a little bit and more and more and more, until now we've covered quite a big range of our healthcare workers. And when we said frontliners, it also included our police, our military, our people who had to monitor the situation, our partners. We've even recently started to include the school teachers, to just safeguard what's happening at schools. So what we did is we actually have 4 phases for the campaign, and each phase is also divided into subdivisions, just to make sure when we're announcing and advocating, we repeatedly say, we are in phase 1, we are in phase 1 A, B, C. At this time, we are including this age group. this category of people. And then when we announce an expansion of our campaign, it's because a new amount of stocks have arrived into Qatar. So our campaign was made into phases in sync with the arrival of the stocks of the vaccine into the state. So thank God, so far we have not faced an issue. I know some countries did face it, where suddenly they ran out of stocks. And that caused a bit of an issue with the community. You just encouraged us, and now you're telling us you don't have the vaccine. So far, I have to say we were lucky enough that the plan has worked. We have not hit such an obstacle yet. And I hope I've addressed all your points, Michelle, and answered your question.
Thanks so much. I just wanted to flag questions from our panelists in particular in the chat. So thank you, Preeti, for the questions on what about funding constraints, any suggestions to overcome those, and then did any of your countries indemnify the vaccine supplier? Were there any concerns? And then Joanne asked about the point that Soha was making about the world coming together for distribution. So would that mean COVAX? While you're thinking about how to respond to those, our speakers today, I guess I would just say to Michelle's last point on the wild market, you know, even if we have a situation in which everybody's really well prepared and ready to negotiate their contracts with money at the ready, on the one hand, that's great. On the other hand, you still have the Wild West scramble, and then who goes first? How do you, so yes, we want it all upstream, but if you still have a sort of survival of the fittest approach, how does that work? So I think there are different angles to this that need to be thought through. Does anybody want to come in on those? There are other questions in the chat as well from colleagues. Carolyn's posted one, and other colleagues have posted them, but I just wanted to highlight those ones from the independent panelists. Any thoughts from speakers?
Hello. Yeah, so and for Liberia, funding is an issue, but not as major as we see it. And what do I mean by that? We know under the COVAX facility, there wasn't any provision or allowance for operational cost. So what that means is that country had to engage multilateral banking institutions as well as in-country partners to be able to access additional resources for operations as it relates to vaccine deployment and rollout. So that was the challenge from the get-go, that we had to work behind the scene to bring on board USAID, the World Bank, other in-country partners to see how we could offset the gaps identified as it relates to the rollout. So yes, it's of concern, and I think for countries that are yet to receive their batch of the vaccine, either through COVAX or through some other mechanism, it's just important to ensure that you start the engagement around the associated operational costs for deployment, because what I know today is that COVAX is not going to provide any up cost, and so it will be upon the country to look for said resources if they have to deploy the vaccine, and that could also impact the implementation timeline or the start date if you don't have these resources available for operations, because it goes with training, awareness creation, production of data tools, safety monitoring, I mean, a whole lot. And so it's very critical. Over.
Thank you very much, Dolphus. It's a few minutes before time, so I think I'm just going to pass to Joanne and potentially the other panelists to Michelle and Preeti, if you want to come in with some final words. Joanne, over to you.
Thank you very much, everybody, for your intervention and all your words of wisdom. I think it's a very, very multifaceted challenge, vaccine, generally speaking. I think that we have highlighted, you know, the logistical challenges, the emotional challenges, the safety issue that we're still addressing with some of the vaccine, the strategy that which one should we embrace, and then I guess the funding. And then I think in terms of countermeasure, I think that you have gave us the different sort of path of answers in terms of the role of communication, the transparency about communication, the education, all the way to the grassroots at ground zero. There's the access in terms of time and physical access, time issued to access to go and get vaccinated, and the role of, I would say, work and employers. I think in terms of countermeasure, more the use of success stories about what is happening in order to, I would say, be able to counterbalance the vaccine hesitancy and or issue of confidence, the roles of leaders and religious leader. And then I guess, Soya, your pre-planning, I guess was your top level message, if I gather. I think this is really rich conversation. I think now for us, what we need to do, and then this the next exercise, and then my co-panelists can help is we need to shape that into recommendation that is actionable and anchor in reality. So I think this is what we're going to do until May, and hopefully that's going to be up to expectation and to the challenge. But maybe I turn it to Priti or Michelle if you want to add something. So I turn it back to you, Eloise, and thank you very much.
Thank you. Thanks everyone for being here today. Thanks to all of our speakers. Wonderful to go from Qatar through Africa, hopping across to Argentina and landing the northwest of the US. Feels like we've covered a lot of ground and also uncovered again some similarities in the challenges that we all collectively face. Thank you to the panelists for doing the work of the independent panel, and don't hesitate to call on any of us to help you in these crucial last couple of months. It's a real privilege to be able to contribute in a small way, and we wish you all the best and look forward to seeing those recommendations. Thank you, everybody. Have a great rest of your day wherever you are. Goodbye.
Gracias.
Bye.